A 58-year-old female presents with persistent lower back pain. I am showing you the radiograph of the lumbar spine. Describe the findings.
Let's see. Yes. The AP radiograph of the lumbar spine demonstrates diffuse, homogeneous sclerosis of the fourth lumbar vertebral body, producing the classic ivory vertebra appearance.
What is the differential diagnosis for an ivory vertebra in an adult? And how do we differentiate the causes?
The differential diagnosis for an ivory vertebra can be remembered by the mnemonic METS LPEM, which stands for Osteoblastic Metastases, lymphoma, Paget's disease, hemangioma infection, and mastocytosis. We can differentiate Paget's disease because it typically causes vertebral body expansion and vertical trabecular coarsening with a picture frame appearance. Hemangiomas also cause expansion and coarse trabeculations but occur in a younger age group. Infection is distinguished by end plate destruction and narrowing of the adjacent disc space. Lymphoma may present with an associated paraspinal soft tissue mass, causing anterior vertebral scalloping.
I am showing you comparison radiographs and magnetic resonance images of the spine. Describe the findings and how they relate to the differential.
The first fat-saturated sagittal magnetic resonance image shows a single sclerotic metastasis as a focal area of low T1 and T2 signal in the fifth thoracic vertebral body. The second sagittal fat-saturated image demonstrates multiple osteoblastic and lytic metastases scattered throughout the thoracic and lumbar spine, representing diffuse metastatic disease. The last comparison radiograph shows very high-density bone cement within collapsed lumbar vertebral bodies following a vertebroplasty procedure, which can mimic the high density of an ivory vertebra but is easily identified by its characteristic acrylic cement distribution.
Discuss the pediatric causes of an ivory vertebra and contrast them with adult causes.
An ivory vertebra is much less common in children than in adults. When seen in a pediatric patient, it is most frequently caused by Hodgkin's lymphoma. Less common pediatric causes include osteoblastoma, medulloblastoma, osteosarcoma, or neuroblastoma metastases. This contrasts with adults, where the overwhelming majority of cases are caused by osteoblastic metastases from prostate carcinoma in men and breast carcinoma in women, followed by Paget's disease and lymphoma.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior lumbar spine studies to determine the chronicity of the sclerotic changes. I would suggest obtaining MRI of the entire spine to evaluate for other subclinical metastatic deposits, spinal canal stenosis, or cord compression. I would recommend a nuclear medicine bone scan to stage the skeletal system and coordinate with the clinical team to obtain a mammogram and a staging CT of the chest, abdomen, and pelvis. I would promptly communicate the suspicious metastatic finding to the referring clinician and refer to oncology.